is an assistant professor in the Division of Hematology and Oncology at the University of Alabama at Birmingham School of Medicine and the O'Neill Comprehensive Cancer Center. She's a cancer and genetic epidemiologist. She received her medical degree from Egypt and her PhD in public health from the University of Alberta, Canada. Her interests are centered on cancer outcomes and survivorship research with a focus on identifying high-risk groups and developing individual risk profiles to inform targeted interventions aimed at improving treatment outcomes for cancer survivors. And given the title here, I suspect we're going to hear more about this. So I'm really looking forward to it. Dr. Sharafeldin.
Thank you so much, Dr. Norris. Thank you so much for the wonderful and warm introduction. And again, thank you so much for inviting me and for being here this early in the morning for everyone that's made the time. I appreciate it. And I look forward to sharing some of my work with you. So yes, that's from my title of the talk, that's some of the work I'm gonna touch on in terms of developing clinical and genetic profiles to improve outcomes in cancer survivors and how this may get us to be able to implement targeted interventions. So, if you will, in 1953, Watson and Crick discovered the double helix structure of DNA. And exactly 50 years later, that huge announcement came with the completion of this very ambitious project at the time, the Human Genome Project, which essentially provided us with this blueprint of our human genome. And by means of which we were able to determine the sequence of over 3 billion chemical bases that make up our human DNA. Now, the fascinating fact is that we share over 99% of that sequence, and it's in that remaining less than 1% is that what the relevance lies in terms of those common variations that that vary between one individual and the other and could influence how people differ, for example, in terms of risk for disease or the response to drugs. Now, when it comes to our ability to interrogate, or what the Human Genome Project first allowed us to is to interrogate the human genome at now various levels of resolution, allowed us to continue to appreciate more the genetic basis of disease, specifically common diseases, and underscores the importance of why it is important to study and understand the genetic architecture of common disease. Now, over the last 2 or almost 3 decades, we've indeed witnessed rapid technological advances that was driven by the high demand and allowed us to incorporate the study of genetics all the way from understanding the etiology of disease up to the management of and patient care and management of disease and its outcomes. And to quote from the director of the National Human Genome Research Institute, it has produced this beautiful tapestry over here where genomics are more or less now woven into all aspects of scientific discovery and patient care. Now, the basis of disease in general can be broken down into this simplified version where our genetics and the environment sort of dictates what our phenotype will look like. And what's embedded in here is this concept of heritability, which is describes essentially how important genetics is in mediating disease, but at a population level. Essentially, what heritability is the proportion of the total phenotypic variance at the population level that is explained by the genetic variation. And its broad sense is influenced by the number of variants that influence a phenotype, the magnitude of the variants or the magnitude of effect of a gene on a phenotype, the population frequency of the genotypes, as well as the interactions between the genes and between the gene and the environment, which is in contrast with the narrow sense heritability, which refers only to the impact of the additive genetic effects on the complex traits. Now, when we think about the genetic architecture of diseases and of common diseases specifically, and measuring the heritability, of the disease, we need to understand the extent of the genetic contribution of to a specific disease and how that varies depending on the etiology of disease, and this accordingly could inform our plans for management of the disease or phenotype of interest. Now, we all know that, or when we think about the relationship between the number of the variants and their effect size, it's actually more of an inverse relationship in terms of the frequency of the variant of a certain variation in the population versus their effect size. So when we think about the models of inheritance, on one side of the spectrum, there's the monogenic model where there's those extremely rare variants that are present in less than 0.1% of the population, yet carry very strong effects that could typically produce disease in isolation. On the other end of the spectrum lies the more polygenic model of disease, where we are now dealing with variants that are common in the population, that are generally maybe over 5% of the population. However, individually, they have weak effects and may not be able to produce disease in isolation. But considering them together is where we can be able to infer the risk for disease. And it's in this polygenic model of inheritance where most of the complex and common diseases lie, including cancer, and where most of the work that I'm going to show you kind of follows that polygenic model of inheritance. Now, identifying those genetic variants, ideally, what we want to eventually want to use or utilize this information for is to be able to predict the risk for disease or outcome of interest. So in our, if we look at this Manhattan plot, which is the presentation of a result from a genome-wide significance study, and the dashed line here obviously represents the genome-wide significance threshold. If we consider those yellow dots, so these are essentially the SNPs or the variants that cross that genome-wide significance threshold, and they would correspond to this yellow curve here. So they do have some predictive power in of itself, but what we really are after is how we can improve that predictive power. So one way is to be able to leverage the information of, these red dots over here, the ones that did not cross the significance threshold in some way, whether that's through increasing the study sample, through combining studies together, which was early in the Geos eras, a lot of consortia were coming together in order to try and increase that sample size and enhance our ability to discover those genetic variants. Or we can try and approach that methodologically by trying to figure out maybe the interactions between those variants and try and account for those effects in some way. Ideally, obviously, if we are able to explain all genetic variants of a disease, then we would reach almost the perfect prediction of our disease, our outcome of interest. And from an epidemiological point of view, the utility of using this information that we can extract from the population level and use that to be able to infer risk at the individual level. So use our population level data in order to use that later on to identify whether individuals would fall into a high risk group, moderate risk group, or low risk group. So ideally, that's where we want to go with this information. And when it comes to the utility of genetic risk in common diseases in general, we can think of it across the lifespan, all the way from birth till the end of life. And the utility might a little bit differ depending on where we are in the spectrum of the lifespan. So early on, it might have identifying those genetic variants may have more of personal utility in terms of, for example, genetically informed preventive therapeutic interventions. So an individual who is known genetically or is identified genetically to have high risk of cardiovascular disease, their physician could put them on preventive statin therapy, for example. Or another example is genetically informed accelerated screening. So accelerated mammography screening, so starting screening at an earlier age for an individual who has this high genetic risk. Another example is improving the risk-benefit ratio of a screening test that may not have net benefit in the general population, such as PSA screening for prostate cancer. And there's so many examples of how we can use that. But as we go into life, as we accumulate the clinical risk factors, as we go on, there might be a shift a little bit in the utility of identifying genetic risk to more of a clinical utility, and could be helpful in in the design of genetically informed interventions. So genetically informed life planning, for example, for diseases such as neurodegenerative diseases, such as Alzheimer's disease or dementia, and how we can, based on identifying the clinical risk and the genetic risk of an individual, come up with those interventions that could help mitigate the progression of disease. So as we think about this, as we think about how we can identify those genetic variants, how we can best utilize that information, we need to think of what methods we're using. And as in recent years, obviously we all are aware of maybe 10, 15 years ago when the word big data was the buzzword, and how this genetic data became available, and how it's we needed to start borrowing methods from other disciplines in order to be able to tackle this high dimensional data. The same picture happened in cancer research. And this figure over here is work that we did a few years back, where essentially we queried all the literature from the early 1990s all the way up to 2018 that involved some form of cancer research and artificial intelligence applications. And what we found that, and using querying the abstracts and the titles of the manuscripts using natural language processing, what we found is there in more recent years, these top 4 topics, which corresponded to machine learning, AI-assisted medical therapies, AI-based prediction, and precision or personalized medicine. This is where the trend of the literature, and this is where the field was moving within the cancer research field, in borrowing all of those applications and applying those machine learning and artificial intelligence applications to our cancer data. So what I'm going to try and go over for the rest of the talk is just give you a little bit of a preview, if you will, of some of the research and the focus of my work over the past few years. So I was interested in identifying the effects of genes and gene-gene interaction, gene-environment interaction effects on cancers and cancer outcomes. And while doing that, investigate sound methodological applications that could allow us to identify those effects and use that information in order to be able to build those, what I'm referring to as the clinical and genetic individual profiles, and use that to improve treatment outcomes in cancer survivors. And ultimately, all this information will help us or lead us to the implementation of targeted interventions to improve those outcomes in cancer survivors. So some of the work that I've done earlier, looking at gene-environment interactions on colon cancer risk and survival using candidate pathway approach, candidate gene pathway approach. And what we did for that work, we focused on a specific candidate gene pathway, the angiogenesis pathway. And we relied to come up with the hypothesis behind the pathway on online web-based resources, the available gene databases, as well as the work to develop this working pathway figure that we use as a guide for analysis. And this is the figure that we came up with. The genes in the blue box represent those, what we refer to as our primary angiogenesis genes that have function and influence the angiogenesis pathway. And then we considered other genes that we refer to as secondary genes, or which come from other pathways that are interacting with the angiogenesis pathway, such as inflammatory genes, for example. And then we considered 3 specific environmental factors, specifically dietary protein, smoking, and alcohol consumption that have an influence on angiogenesis. And we came up with this figure and of how these environmental factors and genes interact together in order to influence the angiogenesis in the tumor environment, and hence increase the risk for colon and rectal cancer, and may influence as well the survival of patients. So after coming up with the figure, we needed to figure out how can we tackle that analytically or methodologically. And what we decided to do is to try and summarize the gene level effects, rather than considering the individual SNP effects. And as we were thinking about that, we considered two biological plausible ways where SNPs on one gene could be interacting together. So one form is what's referred to as the SNP intersection. And SNP intersection is basically when disease risk is elevated only if all of the SNPs on a gene that carry the high-risk phenotype. So an individual has the high-risk allele, for example, SNP1 and SNP2 and SNP3. If an individual carries all three risk alleles, then they would have an increased risk of the outcome of interest or the phenotype of interest. Another form of how these SNPs might be interacting together at the gene level is the SNP union, where in this case, the disease risk may be elevated in one of several independent ways, one of which may include the SNP intersection. So for example, certain individuals can carry the high-risk allele for SNP1 and SNP2, or the high-risk allele for SNP3. So we set out to try and investigate if we can figure out those effects between SNPs. And we used the logic regression, which is a machine learning approach, in order to investigate those two forms of SNP set interactions. And basically what logic regression does is searches for those Boolean combinations of binary predictors, in this case SNPs, and combines them with those Boolean operators, the and, the or, and the not, or the complement of a SNP. And we use that to search for those combinations, and then we use that information, this combination, or what's referred to as the logic tree, to fit it in our model of interest depending on our outcomes. So for example, in a logistic regression model, in this case, instead of having one independent variable, for example, in a age, gender, or so on, it's now a combination of those SNP effects. For example, a SNP union. And the way this logic tree is presented graphically is like this figure over here. So for example, the individual has the high risk for SNP1 and the complement of SNP2, or they have the high risk allele for SNP3. And we use those, like I said, those combinations as our independent variable in our model and identify the risk for those gene level effects. What we did later is we employed 3 steps of the analysis. So we first identified those gene level SNP set interactions. We then allowed them to interact together to get a pathway effect. And then we allowed them to interact with the environmental factors of interest in order to identify those, what we call the gene level environment interaction effects. And some of our findings, we were able to identify differences in the risk profile for colon versus rectal cancer. And we also identified significant gene environment interactions with all 3 environmental exposures that we hypothesized in our model. And some of those top interactions are listed down here. And really the whole idea of all of this exercise is to use that information, like I said before, is to help us identify or provide insights into how we can utilize those information into screening, preventive strategies, or even further intervention strategies based on this individual risk profile. Now, moving on to from the etiology of the cancer risk to the management or the etiology of the cancer outcome. And this is more of the more recent work that I focused on in terms of the outcomes of cancer. Specifically in some of the work I'm going to show now focuses on cognitive outcomes in cancer survivors, and in a specific population, the hematologic cancer population that's treated with BMT or bone marrow transplant. So hematologic cancer patients who are treated with BMT or bone marrow transplant, it's been in the more recent years been more of an more and more increasingly recognized treatment outcome after BMT. And some of the domains that are affected by where the cognitive function is affected include memory, learning, attention, concentration, and executive function. And really, what patients would complain of is what is referred to clinically as the chemo brain or chemo fog. And it actually challenges the patient's critical day-to-day activities. For example, their ability to keep up with their medical appointments or management of their medication. And in some in our older cancer population, has been identified to have some detrimental effect on their survival. So it also has been shown to have this negative effect on their ability to reintegrate back into society and their ability to return back to work or school. So in the BMT population specifically, long-term follow-up have shown that there is recovery for most of the domains. But however, there are still some persistent deficits in almost 40% of the survivors, which is a very high and appreciable proportion of our cancer survivor population that's treated with BMT in order to have all of those lingering cognitive outcomes years out of transplant. So what we wanted, despite all the information and the interest in the cognitive outcomes in the BMT population, there are still certain gaps that we were not really well defined. So some of them, for example, most of the work was focused on patients receiving an allogeneic transplant. So an allogeneic transplant is when the individual receives the transplant from a donor, whether that be a matched or an unmatched donor. And most of the work has focused on that population. So we weren't clear on what is the trajectory, for example, in the other forms of transplant, such as the autologous transplant, where the transplant is from the individual themselves. Another important gap was the varying the effects of the varying intensity of conditioning that the patients receive. Whether there's a difference in terms of receiving reduced intensity conditioning in terms of the chemotherapy and the radiation they receive versus receiving the full intensity of their conditioning, their chemo and radiations and dual radiation. So what are the effects of this different forms of treatment that the cancer patient receives? The other interesting piece is obviously the observation of variance in the inter-individual risk or susceptibility to those cognitive outcomes, which begs the question or supports the idea that there could be an effect for genetics on those outcomes that are having this differential effect in the susceptibility of cognitive outcomes. So really what we want, the work that I'm going to show you now initially started to, or the goal was to try and tackle those gaps and answer those missing pieces. And what I'm going to really try and show you here is the work that I've been doing over the past few years in terms of the full study of cognitive outcomes in cancer survivors, which we can translate to other outcomes in different cancer populations, but just show it to you in forms of a model of how we can tackle specific outcome of interest and to the point where we can be able to design the perfect or near perfect targeted intervention. So the first step you would think of is trying to understand what is the trajectory of the outcome of interest, in this case, the cognitive functioning, and what are the predictors of interest. So in terms of what are the demographic predictors, what are the clinical predictors, genetic, functional, what are all of those predictors that put a certain individual at increased risk of the cognitive outcomes. And like I mentioned early on, like the ultimate utility is to use that information in order to be able to predict risk and identify those individuals at higher risk of outcomes versus those who are at maybe moderate or low risk of the outcome. And as we do this work, another piece that I think is very, very important, and as more and more this genetic information is becoming available, is becoming more and more accessible, is becoming more and more part of the clinical decision-making process in the management of the disease and disease outcomes, is to consider the patient side. So what is their acceptability levels of communicating this genetic risk to them? And how would that influence their own process of decision making in terms of incorporating this genetic information and how they decide, for example, to uptake a certain treatment or uptake a certain intervention? And obviously, an important question is for us to try and answer is what interventions that we can offer to our patients in order to mitigate those outcomes. And hopefully when we have all of those pieces together, put together, we can eventually reach our goal where we are able to implement those interventions that are targeted towards individuals who are at highest risk of those outcomes and who would hypothetically or benefit the most from our intervention. So let's talk first about the first pieces to describe the trajectory of cognitive function and the predictors of cognitive outcomes in the BMT population. So the first cohort, the cohort that we used as our discovery cohort, is a cohort that was procured by Dr. Bhatia at UAE when she was at City of Hope, which is a prospective longitudinal study of BMT recipients, autologous and allogeneic BMT recipients who were receiving a BMT for hematologic malignancy, all adults, English speaking. And the study also accrued matching healthy controls who were matched on age and sex and were not had no history of cancer before. So in this study, we had the DNA on the patients, we had the clinical information on those patients, and we had the information self-report on their demographic variables. And our cognitive outcome was measured using a standardized neurocognitive battery that was administered at predetermined time points. So prior to transplant, to get a baseline before they are receiving the conditioning transplant therapy, and then at 6 months post-transplant, and then post-transplant. And this battery was, like I said, a comprehensive battery that covered 8 cognitive domains. So processing speed, executive function, verbal speed and fluency, working memory, auditory memory, and visual memory, as well as fine motor dexterity. And that involved a slew of 14 subtests that covered those 8 cognitive domains. As part of the study, we also had baseline IQ level, which basically allowed us to identify what we refer to as their baseline cognitive reserve, as well as measured other measures, including fatigue at all the time points. So we had really comprehensive and very detailed definition of the cognitive outcomes prospectively and over time on those patients. Our outcome of interest was obviously the cognitive outcome, and the way we measured that is through coming up with this summary score, what is referred to as the global deficit score, which essentially summarizes the effects of this full battery that I showed you. And in order to come up with the global deficit score, or the GDS, the row test scores from each of the tests was first of all adjusted to the practice effect, since the tests were administered at the repeated time points. And then these T-scores were converted to deficit scores that range from 0 to 5. The deficit scores were then averaged across all tests to come up with the GDS. We also used a binary predictor of cognitive impairment. So using a cutoff level of 0.5, which has been shown in the literature to yield optimal balance between the sensitivity and specificity of classifying cognitive impairment. The other cohort that we used in order to replicate all our discovery findings is another large cohort of bone marrow transplant survivors that is also Dr. Bhatia is the PI on the blood bone marrow transplant long-term follow-up study, or the BMTSS study, which is an independent, non-overlapping cohort. And it includes BMT recipients starting from 1974 up to 2014, and who survived at least 2 years after BMT. It involves a very extensive survey that collects information on demographics and self-reported outcomes, including cognitive outcomes, and medical records were abstracted for those patients to get the clinical variable information on them. Our cognitive outcome in this BMTSS population was a self-report of the cognitive problems by the patient as identified by their healthcare provider. So not necessarily a subjective reported cognitive problem, but rather a report that they were diagnosed by a healthcare provider to have cognitive issues. So what were our findings when we looked at the trajectory of cognitive function in our City of Hope population? What we found is this picture over here. So like I showed you, we have the measures of cognitive outcomes all the way from prior to transplant, and then at 6 months, 1 year, 2 years, and 3 years. And the red graph over here represents the healthy controls or the general population. And as you can see, our BMT patients all performed, compared to the control or the general population, had lower levels of cognitive functioning. And the most compromised group was actually the group who received what we call the myeloablative allogeneic transplant or the full intensity allogeneic transplant. And we saw that picture persisting over time and across different domains. So for example, in measures of executive function, we saw the same picture among the allogeneic transplant patients who in the verbal fluency and verbal speed. And in different tests and across the domains, we saw the same picture where the compromise was the most among the allogeneic transplants, specifically those receiving the full intensity conditioning. And when we looked at the GDS, the overall measure, we see the same picture over time, a significant trend in the cognitive decline or impairment over time, and the overall effect as well in the full intensity group over 3.5 times the odds of cognitive decline throughout the study in comparison to the healthy controls. So we were able to show that, yes, indeed, there is a cognitive decline in this population, and it's more seen or more evident in the allogeneic, specifically the full intensity allogeneic transplant, not so much in the autologous transplant population or the patients who received a reduced intensity treatment. Some of the factors that we were able to identify to be associated with the increased risk of cognitive impairment in terms of the demographic and clinical factors included older age at BMT, male gender, lower education and income, and lower cognitive reserve at baseline. All of those factors had a significant effect on increased risk of cognitive decline after receiving the transplant. What we also were able to show is that in that most compromised group, the myeloablative allotransplant recipients, over 46% of them had not returned to work after transplant 3 years out of transplant, which is a significant time following receiving their treatment. And patients who had evidence of cognitive decline had a 10-fold increased odds of not returning to work. So it is clearly a problem for those patients that is affecting their quality of life and their ability to go on with their lives following a cancer diagnosis and cancer treatment. In terms of switching back gears to the genetic piece, what are the genetic predictors of cognitive impairment in that population? We examined that in a few different ways. So the first one was through the candidate gene approach. And essentially the hypothesis behind this candidate gene approach is to test this hypothesis that high doses of the treatments that the patients receive, the chemotherapy, radiation, the steroids that they receive, result in increased oxidative stress. The high level oxidative stress then induces telomere shortening, and these critically shortened telomeres result in DNA damage, which results in neurodegeneration and increase the risk of cognitive impairment. And based on this hypothesis, we selected specific candidate genes along those specific groups of genes. So along the blood-brain barrier transporter genes, along DNA repair genes and telomere homeostasis genes, neural repair and neurotransmission genes. And the genes we looked at, the variants, we looked at included around 68 genes with over 1,000 SNPs that we considered their individual effects as well as their gene level effects on cognitive outcomes. So first, looking at the individual effects of the SNPs, we identified 7 SNPs that had significant effects on cognitive impairment. We also looked at the gene level, employing the same method that I described earlier in terms of looking at SNP interactions and using the logic regression to come up with the gene level effects. And what we found is using the individual SNP or the single SNP analyses and the gene level analyses that we were identifying variants along the same 3 groups of genes, the DNA repair genes, the blood-brain barrier genes, and the telomere homeostasis genes. We also investigated the genetic predictors of cognitive impairment in this population using the Geos approach and fitting several different genetic models, the additive genotype and codominant model, and we were able to identify or discover 44 Geos SNPs that crossed the genome-wide threshold. And out of those SNPs, 2 of them were successfully replicated in our BMTSS independent replication cohort. So what we did next with those variants, what I'm going to show you is the next step where we try to use this information for the next step to be able to identify the levels of risk for individuals. So I'm going to show you first what we did with the candidate gene findings. So we used those to, using the post-BMT GDS as our outcome, to build risk prediction models, 3 distinct models, prediction models of cognitive impairment. We used logistic regression models using elastic net regression to address the feature selection and overfitting of our models. And we essentially created 3 distinct models. The first model was what we refer to as our Bayes model, which is a just considering demographics. So only considering the patient's age, sex, race, education, income, and marital status, and trying to figure out how does that influence their level of risk. Next, we added, over and above the demographic variables, we added the relevant clinical variables and to see if that would enhance our predictive power. And then eventually we combined all of that information in what we refer to as our combined model, which is included those significant variants that we identified from our candidate gene analyses. And what we were able to show here is that our ability to predict risk by incorporating the genetic variants enhanced our performance of our models. So the red curve here represents the Bayes model, which includes only the demographics. When we add the clinical information, our predictive power is enhanced. And then we reach the best prediction when we incorporate the genetic information beyond what is offered by the demographic and just the clinical information. And all those differences were actually statistically significant. We were able to replicate that same picture in an independent cohort, the BMTSS cohort, where we were able to show that indeed the same relationship holds in where when we consider the genetic variants over and above the demographic and clinical information, it enhances our ability to predict our outcome. Our next step was to use the Geos information, and one very popular method to use that Geos information is to develop the polygenic risk score, the PRS. And for those who are not very familiar with the PRS, it is based on the concept of the disease that our diseases follow this polygenic risk model that I have alluded to early on. And basically we use that those Geos summary information and following some form of adjustment to the variants that are in LD or in linkage disequilibrium, we account for that, and then we get the summative effects of those variants while accounting for the dosage in terms of essentially how many risk alleles the individual has. We test the PRS in a population, and then we, as with everything in genetics, we validate those in an independent population. And the idea is to come up with this risk gradient for the PRS percentiles where we can identify those who are this differential form of risk of people who are the lowest PRS percentile versus those who are at the highest PRS percentile. So in our data, we used information from our GWAS SNPs, and following LD pruning, we included 24 SNPs in our PRS. Like I said, it accounts for the SNPs effect size from the GWAS effect size, as well as accounts for the dose of the risk alleles for each of those SNPs. And then we consider the PRS quintiles, comparing the lowest 20th percentile with the highest. And what we found was, again, in our discovery cohort, that patients who, the top over here, patients who are in the top PRS quintile were at increased risk of cognitive impairment with a relative risk of 1 or almost 2. We were able to successfully replicate that same picture in our replication cohort. Another interesting finding was when we stratified our PRS risk by clinical profile, we were able to show that the PRS had the most effect in the individuals with low clinical risk. So in other words, if an individual has low clinical risk for cognitive impairment, that's when their genetics matter the most. We found that as a very interesting observation, because it gives us an idea of which patients would benefit the most from this genetic investigation, or in which patient that genetic information actually may infer more risk. A next step that I'm trying to use to try and answer this question even with more precision using the UK Biobank data. The goal is really to answer the question, is the genome-wide polygenic risk score associated with cognitive impairment in this population? And will the magnitude of this PRS association indeed vary by the clinical risk? So moving on, like I said, now we have some idea or picture of what puts an individual at increased risk. We're using that to build our risk prediction models. Comes the piece where is the patient open to receiving that information? And what we did is we, in a survey that we administered to our allo-BMT population, where we essentially asked them some straightforward questions in terms of if you are giving this information about this, describing this genetic risk for cognitive function after transplant, would you be willing to take a gene test? And from the graph on the left, what the patient's responses were that over 50% of them thought, yes, if there's a genetic risk for a specific outcome after transplant, I consider this an important information. The next question we asked whether if you would this information, if you know that you are at increased risk genetically or decreased risk genetically of the cognitive outcome, would this affect your decision with regards to uptake of an intervention? And again, over 50% of them said yes, this would actually affect my decision. If I'm perceived to have increased genetic risk of cognitive outcome, this would indeed affect my decision in terms of uptaking a specific intervention. And we put this in our patients into, we provided them with this hypothetical scenario where, let's say you did take the test and the test either results came back as you having low genetic risk or you have high genetic risk, and individuals were randomized to receiving either survey. And what we found that those who were hypothetically perceived themselves to be at high risk genetically of cognitive outcomes were at 6 times more odds or risk of having that information affecting their decision to uptake an intervention. So essentially what this is telling us is patients are open to that genetic risk communication. They think it's important. They want to know if they are at increased risk genetically for a specific outcome after their cancer treatment, and that this does indeed affect their decision whether to go ahead and uptake a specific intervention in order to mitigate those effects. Now, the question is, after we identify the risk and we know that there's patients are open to those interventions, what are the best interventions out there that we can use that could have that are feasible and that are efficacious to mitigate the cognitive outcomes in cancer survivors. And this study that I'm running here at TUAB is the cognitive training intervention after BMT. And essentially, it's a randomized wait-listed, two-arm randomized wait-listed trial where we offer patients a cognitive training program, the MOSFET program, which is essentially a brain games program. And they play those games online for 12 weeks, and we get a measure of their cognitive function prior to using the intervention and following the intervention. We include adults who received an allogeneic transplant. And the reason why for this intervention we focused on the allogeneic population is because that's the population that we saw was the most compromised. They need to be outpatients at least 3 months out of their transplant and up to 3 years, again, because we observed this persistent cognitive decline that persisted over years out of transplant. They had to have access to an internet-connected device to be able to use the online intervention, English speaking, so we can administer the cognitive outcomes, the cognitive tests, and obviously provide a consent. We excluded individuals who had any evidence of or history of pre-existing neurological disorder, significant auditory or visual or motor impairments, or who have participated in an intervention prior to that. Like I said, we measure their cognitive function at baseline, and there are specific surveys that they complete, and we obtain a pre-BMT sample on them. They are then randomized into either the intervention or the waitlist arm. And the intervention arm immediately uses the cognitive training program. So they start playing the games. And essentially the games is they play, we have designed a program working with Lumosity where it takes them about 25 to 30 minutes a day. And we ask them to play the game 6 days a week and measure adherence if they actually play at least 50%, so at least 3 days a week. And then at the end of the 12 weeks, we measure their cognitive function again. The waitlist arm doesn't do anything during the 12 weeks, and after the 12 weeks, out of ethical reasons, that's when the waitlist arm starts to receive the cognitive training intervention. So far, the preliminary evidence has indicated the feasibility of the intervention. Our overall attrition rate is around 19%. Our median adherence is around 87%. So you can see from the graph here, we have some patients who were using the program religiously, some were not. And most of the reasons why patients would drop out is either they pass away or because their medical condition deteriorates. And what we also showed, and I'm sorry if this is so not so clear, but we look at the specific domains of cognitive function using a similar or comprehensive battery like the one I showed you earlier. And what the signal that we are seeing so far with our almost 50 patients that have enrolled in the trial so far is in the processing speed domain. The red line, if you can see over here, represents the wait list. So you can see there's no change in their scores, where the intervention patients, their scores would, there's a significant improvement in their scores from the pre to post intervention. So basically what the study is showing us so far that providing this intervention to the patients is feasible, and there is some evidence of preliminary efficacy. We are also looking at functional markers for in our patients, and we are performing MRI scans of them at baseline and at 12 weeks. That involves a structural scan and resting state and task-based scan and DTI. And basically what we've shown so far is it's early, obviously, to look at those differences or be able to get some results. But what we're showing is that there is robust connectivity of the regions of interest that are involved in two specific networks, the executive control and the attention network in the brain. And it's telling us that we have evidence of the feasibility to effectively assess the resting state networks, at least in this population. An interesting piece, just very quickly, is as if big data is not big enough, is this emerging field where the MRI data is combined with the genomics whether that at SNP level or pathways or PRSs. So in other words, methodological approaches that are coming up in order to, like what I showed you before, integrating clinical or demographic or clinical genetic information, but also include those functional information into those models in order to be able to predict risk outcomes. So another area that is emerging in high interest. So some of the next steps is continue obviously enrollment on the study and determine the efficacy of the intervention. And like I mentioned, investigate the neuroimaging correlates of the cognitive function, as well as use this population where we have now this prospectively measured outcome in order to validate the risk prediction models in this cohort. Another ongoing study that's just started almost less than a year ago, examines the cognitive outcomes in another cancer survivor population, and just showing this to show you an example of where we can move this model to another cancer population, another cancer survivor population, and could be deployed for the study of several outcomes, treatment outcomes that our cancer survivors suffer from. So the capital study, the cognition in advanced prostate cancer patients treated with androgen blockers. So these are advanced prostate cancer patients who are on androgen deprivation therapy. And there is evidence that androgen deprivation therapy might have a negative effect on their cognitive function. But what we don't know is those more mainstream treatments, the second generation treatments that are offered to those metastatic prostate cancer patients, how would that affect their the progression of their cognitive decline further. So in this study, we are creating this cohort of prostate cancer patients prospectively, where we're measuring their cognitive function at baseline prior to starting the second generation androgen blocker treatments, and then at 6 months and 1 year, and getting DNA samples on them and functional data on them in order to describe the trajectory of cognitive functioning in this population. So essentially, we are at the very, very step in the process as far as the study of cognitive outcomes in the prostate cancer population. So what I wanted to just come back to is this, hopefully I was able to give you some picture of this idea of how we can utilize genetic risk and the utility of genetic risk in common diseases. And like I said, with more focus on the clinical utility and our ability to use all that information to implement what we refer to as the genetically informed intervention. And what I wanted to just touch on very quickly, there's been, like I mentioned early on, there's been huge advances in the field. Early in 2020, the strategic plan for the next decade was announced, and we're almost 2 years into that. And the bold predictions for human genomics by 2030 were published. But what I wanted to touch on is a few of them that I think are relevant to some of the work that I showed you. One of the bold predictions is that every human gene will be known by 2030, that this use of genomic information will become mainstream in the clinical setting and in the management of diseases and their outcomes. So we really, it's coming upon us, and we really have to keep that in mind and be prepared for that. And even more, another important prediction is that this complete genome sequence, along with the annotations, will become securely and readily accessible to individuals, even up to on their smartphones. So, and we are seeing that already. So we need to be prepared and ahead of the curve of how to utilize that information and how to communicate that risk and help our patients understand how to use and process this information. So I'm just wanted to end with pictures of some of the amazing individuals that I've worked with over the years. This is the Itaka Isui's, my PhD mentor group back in Edmonton, Alberta, where I did my PhD. And this is our group at Institute for Cancer Outcomes, led by Dr. Smita Bhatia here at UAB. a huge diverse group. And this group has even tripled now. There's no room to put us all together anymore. But again, a whole group of individuals that that I've enjoyed working with over the years. And just a quick thank you to all my mentors and all my colleagues that I've worked with, the funding that I was lucky enough to receive to support this work. And obviously, as always, the ultimate thanks to the patients and their families for allowing us to do this kind of research. And I'll stop here, and I hope there's a few minutes for questions.
Thank you so much, Dr. Sharafeldin, for such a comprehensive look into what you've been doing and the importance of this. So I appreciate it. I'm hoping there is some time for questions, and I want to make sure that we allow anybody who wants to ask a question, just unmute. I think it'd be easiest just to ask it. Anyone?
I've got one.
Wonderful.
And I'll just reiterate, that was just fascinating. And it seems like there's actually such good work that's applicable to actual patient outcomes. So it's really exciting. I wonder if you could just talk in general about the issue of equity in your work. I was thinking about the opportunities for transplant, the opportunities for one type of transplant versus another. Are there biases in who gets which type of transplant? And are there implications sort of at a population level when you think of disadvantaged populations, especially when you're thinking about environmental structural issues and the impact on cognition? So I know that's a very general question, but I just wonder if you could touch on some of the equity thoughts you have.
Yes, of course. Thank you so much. Well, I mean, the decision or the clinical decision in order for a patient to receive transplant is mainly driven by their clinical diagnosis. So which hematologic cancer, that's really the drive behind the decision whether to go with an allogeneic or an autologous transplant. There is also, in terms of the conditioning that patients receive, is also dictated partly by their specific factors. So for example, older patients, more reduced intensity conditioning would be more favorable. But again, the big question in that area is, like you said, in terms of equity, in terms of, and that's where a lot of work and in terms of access, patients who receive an allogeneic transplant and need that transplant from a donor, and whether their ability to access that donor and what is the quality of that transplant as well. Because what we know, what some of the indicators that show that the donor stem cells could indeed have some effect on the outcomes of the transplant. So accessibility, all of that, there's so much interplay in how the patient would, their response to the transplant following that. So that's the clinical piece. But then in general, like you said, when it comes to the cognitive outcomes, like we've shown, when it comes to the actual non-genetic predictors, we find education and we find income and we find the cognitive reserve, like what the level they come into the transplant with really dictates how they're going to fare after. So if they come in with a very low cognitive reserve, that really puts them at much risk of how they are going to fare after transplant, unfortunately. So yes, definitely there's a lot of this work. The other, I think, from a genetic piece that I'm really always, concerned about as well, in terms of the diversity and of the genetic the population that we're studying genetics on. So we are generally focused on people who are from European ancestry, and we identify all of those genetic predictors based on that genetic makeup, and then we try and take that information and just apply it across the board. And that doesn't really, just from the straightforward thinking, it doesn't make complete sense, because what we've shown over and over again is, depending on the makeup of the ancestry of the individual, their genetic risk, it differs. So what is genetic risk in a patient with a European ancestry may not carry that same risk. So, and when it comes to the question of the PRS and all the excitement about the PRS and developing those PRS for this and this and that, all those PRSs, if you look at, like I showed you, are coming out of those Geos studies. And when you trace it back, all Geos studies were done from individuals who are coming from European ancestries. So I use that to come up with some kind of risk profile and try and commercialize that and say, okay, run this test and that's based on your PRS, and it doesn't really translate to a person from a different ancestry. So it is very, very, but there's, on the bright side, there is a lot of work methodologically to try and account for that. And also a lot of work in order to diversify our genetic populations in order to be able to answer that question more comprehensively. So yes, definitely, all the way from deciding how to treat the patient, all the way to how to manage their outcomes. Thank you for that. Yeah.
Yeah, thank you. I'm getting a little bit of feedback. I realize that we're over time. I see that a number of people probably will be meeting with you later. I probably want to be respectful of everyone's time and end the meeting, but and I need to go to the next meeting as well. But if people wanted to stay on, that's great. But I'm going to have to leave, and I